All right, so I want to do a video on biliary drains. And so really the whole idea of this is to talk about what we're doing and trying to accomplish. Maybe some of the different patterns that we see when we're doing this. Also talk about really for the nurses and RTs, the room setup, what we're doing from an antibiotic standpoint and just kind of what equipment we use. And so we'll jump in. So the anatomy here is very simple in terms of what we're trying to accomplish. The liver hangs out in the right upper quadrant. It's about the size roughly of a football, if that helps kind of put it in perspective. It does a lot of things. One of the major functions of the liver is to create bile. And bile is chemically, it's like a soap. It's an emulsifying agent to help you digest fatty foods. And so bile is made in the liver cells. It's translated into these little bitty ducts that coalesce into a right and left main duct that then end up in the intestines. So not shown here, it meets up with the intestines right near the inflow of the pancreatic duct, and the pancreas is kind of hanging out right in here. And so it makes sense if you think about it. The liver is making bile. Bile helps you digest fat. The pancreas is making enzymes that help you digest protein. They come together in an area of the duodenum just past the stomach where you have this food that's kind of macerated and ready to be broken down and digested. And so, what can happen, and I bring this up, because what can happen is a pattern of bile duct obstruction from a pancreatic mass. And so I would say the number one, or at least one of the main patterns of bile duct obstruction is from a pancreatic cancer or an ampullary mass, and the ampulla being the area where the bile duct comes into the duodenum. And so if you have a mass in this area here of the pancreatic head or ampulla, it will block up the bile ducts leaving the liver, and that results in obstruction. It's also hard for an endoscopist to come in through the mouth, through the stomach, and into this area and be able to see and be oriented in order to cross this blockage and place a stent to decompress. And so this distal common duct, pancreatic head, ampullary region is one of the main reasons why we put drains in. When we do this, these drains are typically single drains, and they're mainly to give us access into the biliary tree to get a biopsy, put a stent, and leave a drain. And so those are the three things we're trying to accomplish. Many of these come as a failed ERCP, and we know there's a mass there. And so in these situations, we try to do really all of these three things at once. We put the patient to sleep under general anesthesia, and we attempt to place a drain. There's some debate right now as to whether you should do this through a right-sided or left-sided drain access. The left-sided ducts have less pain, they tend to have fewer maintenance problems, and they tend to work a little better on average than the right-sided drains. But the angle from the right-sided drains to place a stent tends to be a little better. And so many, if not most of the time in this situation, we're looking at a short-term right-sided drain that stays in for a few days after we stent and biopsy. So distal common duct obstruction, single drain, we do a lot at one time, and so we tend to put these patients to sleep under general anesthesia. The other common scenario that we see, I think we've seen a couple times in the past week, is this hilar blockage, and the hilum is the region of the central liver where all these ducts, arteries, lymphatics, and blood vessels come together. And so where the right and left main duct come together, there's a potential for a biliary tumor, a cholangiocarcinoma, or a metastasis to cause a blockage in the area where this confluence occurs. And in that situation, we would put a drain in from the right side and the left side typically. And then depending on the pattern of obstruction, we would then eventually, hopefully, talk about removing those drains and replacing them with stents. And the pattern is important because it would let us know whether we could put metal stents in a Y formation or plastic stents. And so how do we differentiate that? Well, let's say these ducts here come in together, and there's several other major branches that are all coalescing here right near the blockage. If that occurs, most of us like to put plastic stents in because a metal stent is difficult to land without compressing and blocking up these other small segmental ducts. And so a metal stent in this type situation can make the blockage worse. by compressing these other ducts that are trying to reach their inflow at the same point. And again, this is getting a little bit in the weeds, but just so you know, so we're getting in, if we have an obstructive pattern that looks like this, where the ducts really come in and there's a blockage with a nice landing zone for a metal stent, then we could put Y-shaped metal stents, which are a little bigger in diameter and last longer. So plastic stents in one pattern, metal stents in the other pattern of blockage. Regardless of what we're planning eventually in this situation, we tend to put bilateral drains, and then we get a biopsy at the same time typically. And so for this, again, when we're placing two drains, anesthesia is helpful. These patients go to sleep because there are a lot of moving parts. So occasionally, if we have a unique situation, like a metastasis just blocking up the left side and very dilated ducts, then we'll do that case with sedation. But as a rule of thumb, these cases are more or less always with anesthesia in our practice. And so that would be kind of a situation, again, for us, where we would be thinking about single drain and using sedation. So we've got two major obstructive patterns. We've got hilar and we've got distal common duct. We've got what we've tried to accomplish. I would point one more thing out here, that the gallbladder is a reservoir that's coming off the common bile duct near this confluence. And if the gallbladder can't drain because of stones, or occasionally if there's a blockage distal in the common duct and the gallbladder gets dilated and infected, then we place a drain called a cholecystostomy tube, and that's less invasive. That is a sedation, light sedation case all the time, and that takes about usually 5 to 7 minutes with some local and a little light sedation. And so that's a separate procedure. The only thing really to know is that these cholecystostomy tubes have to stay in place for about 6 weeks before we pull them out, because they can leak bile out into the abdomen if we don't. So a couple different moving parts. Wanted to mention antibiotics. So whenever you have an obstruction, remember these ducts connect to the intestines, and there's typically some potential for bacterial colonization. And so if you have bacteria in the ducts and they're blocked up, then that bacteria can proliferate. And so we like to sterilize that bacteria with an antibiotic that is excreted ideally into the biliary tree. And that would basically be a fluoroquinolone. And so in our practice and in most practices, they're using Levaquin as our prophylactic antibiotics. And so these patients need prophylaxis with Levaquin in more or less every situation. Also, when we do biliary tube exchanges, good idea to give a dose of Levaquin. Lastly, in terms of room setup, we like to mark these ahead of time to make sure that we're prepping the right location. I plan for a 10 French biliary drain, the exception being when there's a really tight stricture and I can't advance the tube. And so even though I plan for a 10 French drain in most of these situations, we tend to not drop a tube ahead of time. We make that a game time decision once we get in the ducts. For all of these cases, we like our coaxial system, our McInV, a Nitrex wire to start with, a glide wire, and a Kearns, or your standard 65 centimeter angled hockey stick type catheter. And then I think that pretty much covers everything. Hope that helps. Thanks.